You want to spare the low back, you do your activities in a neutral spine. You lift weights, neutral spine. You pick something up heavy, pick up your children. You act as a doctor, adjusting however many patients you do a day, neutral spine. So you're going to do supine for down and lateral on the ASIS. Down and lateral on the ASIS. Hands like this. You got to use a lot of pressure. There you go. You feel pressure in there? Put your body weight into it. Down and out. Good. You push. Does that hurt? Yes or no? On the symptomatic side. That's test one. Functional training in our practices is really what we're trying to accomplish. And the needs of an office, which I think all of you already have, are the medicine balls. Raise your hands if you have the medicine balls. When I have patients doing wood chops as a warm-up, it's great, and I'll show you a diagonal pattern or a PNF pattern to use with that. Or if I just had one in here, we could throw it around to each other as a warm-up. And the beauty of it is it's sudden, right? It's throwing, so it creates, core stabilization while they're on a rocker board or a wobble board, or if they're on a ball, we can do a ball toss just back and forth. This is the stability ball. The medicine ball is MB. Right, so this is how we did it. Did we do this one yesterday in the circuit?
No,
we demonstrated. Yeah, we did do that. So this is squats, right? Stability ball, one-legged squats. So I'm doing double stance right now, and then I go to single leg. How many do I do?
100.
Yeah. I'm going to take them to that place. So I'm palpating the suboccipital area. I'm just lightly palpating. I'm not squeezing and I'm not massaging it. I just put my hands there and I take a reading. That's all I'm doing. Just take a reading. And then I have you're observing the suboccipital tone while the patient stands, and you keep repalpating when he sits. Does the tone decrease from standing to sitting? Is there a difference? Sit down. Stand up. No, not much change. If there was a change, the pelvic dysfunction is contributing to the upper cervical occipital tension. Doesn't that make sense? When he's seated, is the pelvis in play?
No.
No. When he's standing, he's activating the pelvis and the pelvic muscles. So I'm looking for a noticeable change. Or somebody... Is that good stuff on the SI joint? To really make you better diagnosticians.
You're supposed to have the SI joint off the side of the table, right?
On Gainsland's, yeah. It should be a little more further lateral. Good.
What?
On Gainsland's, this should be off the table.
On the trochanter ball, why is it going as 2?
Say that again.
Yes, why is it going as 2?
Oh, because you know what it does? It takes this area, the sacroiliac, and it compresses it in. Right? It holds it in. The problem with the sacroiliac, it's all ligaments in there, right? The SI joint is ligaments. So usually if there's an irritation in there, it's being separated. These joints have actually separated where they become hypermobile. They're too loose in there. And when a patient moves, it's unstable. So there's lots of muscle splinting and guarding. So now you're putting a belt on it, and it's making that area more stable. So they can't. Now here's the deal. My patients are typically, my patient population is just like yours. They're probably 30 to 55 years old. But I do have a lot of seniors. But they have a lot of low back issues and leg pain issues. Typically they've been to their doctors, right? They've been to their doctors, they've tried different things. I sit down here and this is my examination with them. Going through this. You've had an epidural injection already? Yes, I had. How many did you have? I had 3, because that's usually... Okay. So how can we improve Dean there a little bit?
Stretch the legs.
I can see though, wait, let me comment on that, because, so Dean,
It's compensating.
yeah, I would let Dean, do it like that.
Yeah.
I won't force him into, any other position.
We're working the glutes.
Alright, so back straight, Dean, back straight, there you go, no, keep your foot up, back straight.
Not bad, feel like a squat.
Now, there you go. Not necessary, just squat down. There, feel it?
Feel it here?
Okay, how about the other one? Go down a little lower until you get it. Keeping your back straight.
Many lordosis.
Oh, that's right.
That's great. I know what's better.